Hi, it's Kathy again, and welcome to another video, an important video. From admission to aftermath, what happens when an older person goes into the hospital and the reality of this for older adults. For many older people, the hospital door closes behind them with a quiet finality. A wristband that's slapped on, clothes taken away and tucked in underneath the stretcher sound familiar? Time dissolves into alarms and interruptions, many unfamiliar faces. What began as a single problem, a fall, an infection, chest pain, quickly becomes something much larger. Realize that hospitals are not meant to heal. Yet for older adults, they often introduce risks that have nothing to do with the original illness. So while hospitals work well for younger people, they don't as much for older people. The danger is not incompetence or cruelty. It isn't. People are excellent. The danger is its design, the hospital's design. Modern hospitals are built for speed. They're built for efficiency and standardization, and for typical standard bodies. Your average 30 or 40-year-old man, but not for older or aging ones. Older adults don't arrive with simple stories. We just do not. We bring chronic conditions, medication list, often long medication list, fragile balance, history, risk of falls, sensory changes, eyes, hearing, memory loss, and a lack of histories. And history matters. Hospitals are organized around isolated problems. Let's fix that heart. Let's treat that infection. And most of all, let's discharge fast. That mismatch sets the stage for predictable breakdowns that we as families recognize only in hindsight after the damage is done. So let's look at 4 areas that I ran into consistently as a professional RN care manager and also as a family caregiver. The first one, big one, number 1 reason for hospital readmissions. Medications multiply when no one is looking at the bigger picture. The first quiet shift happens at the medication cart. A drug is added for sleep, another for agitation. A home medication is held, for now. Doses are adjusted based on protocols that assume resilient kidneys and livers. No single change in and of itself seems that dramatic, right? Yet together they destabilize an older body very quickly. The person becomes groggy, balance worsens, thinking slows, a fall happens, and recovery stretches out. These medication problems don't announce themselves, but unfold subtly. So what can help here? Bring and keep a current medication list. Question any sedatives and ask every day what has changed and why it changed. Realize that medication safety for older people requires active participation and not passive trust. And the second area, there's a fog that develops in older people, and it isn't dementia. Confusion in the hospital is frequently brushed off as aging or early dementia or some problem with memory. However, what older adults are really experiencing is delirium, very common in hospital admissions. Delirium is a sudden, reversible brain failure triggered by stress and illness and medication and dehydration and sleep deprivation, all the things that a hospital is designed to give you. Hospitals are not perfect environments, but they are perfect environments for delirium in the older person to take hold. Think about it. The lights are always on, sleep is fragmented, glasses, hearing aids are often missing or not put in. Familiar cues vanish, and once a person becomes disoriented, they lose credibility in a system almost overnight, get labeled. The tragedy is that delirium is not only frightening, it is dangerous because it increases the risk of long-term cognitive decline, institutionalization, and yes, death. So what helps? Maintaining orientation, allowing and protecting sleep, and ensuring sensory aids, hearing aids, glasses, are used, and having someone present who knows what the normal is or looks like for this person. Naming it and knowing that it is delirium early changes the entire trajectory of a hospital stay. The third one, the lie of just lying in bed. Just stay in bed, just keep in bed. We have falls that are the most feared in hospitals, especially for older adults. So what's the solution? It's immobility. Keeping them in bed with bed alarms due to short staffing and regulation around fall management. In a matter of days, muscles weaken and balance erodes. 2 days of bed rest can do this, or less than 2 days. An older adult who walked in independently may leave needing assistance, and not because of the illness, but because the body didn't move. And this lack of movement does have consequences. So what helps? Ask early about the mobility plans and request physical therapy consult and plan, and reframe movement, physical activity, something as part of the treatment plan. Fourth, this is well known to all of us. Time to be discharged, but I haven't recovered, right? The final blow comes with rushed instructions, changed medications, unclear follow-up, and families handed responsibility without any preparation. It's time to clear the bed, move them out. The hospital's job is done, yet the older adult is far from stable. This is how and why people end up in emergency rooms days later, labeled frequent flyers rather than victims of fragmented systems. So what helps? We start the discharge conversations early. We've been talking about this for decades. Sometimes it happens, most time not. Demand clarity and refuse to leave with unanswered questions. Knowing the questions to ask becomes key. Oh, so the hard truth. Know that hospitals are not designed for older people. Hospitals are necessary and needed, but they are not designed for the older person. And older people fill most of the hospital beds. Now, that truth is uncomfortable, but it is also clarifying and ultimately empowering, because when we stop pretending that the system is neutral and universally safe, we, our loved ones, step into a care system with our eyes wide open. Think about this. Slow the pace. Ask better questions. Actively protect what matters most. And what is that? Cognition, mobility, dignity, and independence. The way forward does not rely solely on better hospital care. As a matter of fact, avoiding the hospital at all costs is the key. It requires shifting where and how care happens after discharge. So let's look at a couple of options here. Telehealth allows for older people to be monitored, supported, and reassured in their home without that physical and cognitive strain of repeated clinic visits or unplanned hospitalizations. A timely virtual check-in can catch a medication problem or functional decline early before it can spiral into another emergency. Equally important is moving primary care and prevention back to communities. Local community centers, senior hubs, navigational hubs, neighborhood-based clinics are the anchors for ongoing care. Places where providers understand aging, have time to listen, and know the local landscape of resources. We've made a business out of all of this, and this is the number one problem we all have. Community settings are better suited for relationship-based care, early problem solving, engaging in honest conversations, limits, goals. Community supports matter just as much as medical intervention, no matter what's going on. Think about local adult day programs, respite, community resources that reduce isolation and caregiver burnout while also keeping older people engaged. I worked for 20 years as an aging life care manager, elder care manager, geriatric care manager. It's known by different names. These are experienced people who actually know the healthcare system, the aging system, gerontology, and they can translate hospital language, coordinate services, and help prevent families from making costly, panic-driven decisions in moments of crisis. Their services are private pay. Some are more expensive than others. So it's important what's important to you. Paying more doesn't necessarily translate into a better service. But that neutral and objective input does help quite a bit, whether you're planning, preparing, in the middle of it, or dealing with the aftermath.